What is up, everyone? Welcome back to another episode of the Babbles Nonsense podcast. Today we have Miss Ivy back. We are talking all about palliative care and hospice, the difference in between, and then we get into a little bit of a discussion at the end, talking about full codes versus DNR and her experience and my experience, or our views on that, if you will. This is just an educational episode. This is in no way to intend or tell you what you should do in your specific situation. This is just from our own personal experience. So if you've ever been curious about palliative care or hospice, then this is the episode for you. What is up, everyone? Welcome back to another episode. I told you Miss Ivy would be back. We said that in our last episode a couple of weeks ago. She used to work in palliative care, so we kind of wanted to have an episode surrounding palliative care talk and hospice talk, just because we have a morbid sense of humor when it comes to healthcare. Most healthcare workers do. And kind of just to put a little bit more education out there about what the difference between palliative care and hospice is. This is in no way to tell you in your specific situation what to do with your family members. This is just to kind of put a guide out there, put a little education out there so that maybe you can then go research a little bit further if you're having any of these examples in your life with your family members or maybe even yourself.
Excellent.
So Miss Ivy is back. And Ivy, a couple background with her, she's a nurse practitioner that worked as a hospitalist for several years. And then she transitioned from hospitalist to palliative care nurse practitioner. And she did that. You did that for about a year, right?
Yeah.
So I wanted to have her on because she does obviously have more experience in that than I do. And I can talk about the experience that I have when I work, because I do work in some assisted livings and how that conversation goes with family members. But first, we obviously need to start with what actually is the difference between palliative care and hospice.
Excellent. I know, I love the preface because please do not take anything we say on here as medical advice.
Right.
Definitely, I am not an expert, but it's just to get the word out there, what is palliative care? Because so many people haven't even heard about it, and we want to get the info out there, even about hospice, because it should not be a curse word, right? It is an excellent resource. So palliative care versus hospice. It is a resource. So we know hospice is for people at the quote unquote end of life, right? It is a Medicare benefit, interestingly. And the difference is it is for people with a life-limiting diagnosis, be it heart failure, COPD, something that is going to technically end your life in 6 months or less. But of course, we never know when that is going to happen.
Right. And I know that some patients, they're on hospice for years.
Correct.
And I know that that's where some of the disconnect does come from sometimes. Some people are like, oh, well, if you put me on hospice, that means I'm dying right now.
Correct.
And that doesn't, that is not true. That does not mean I've had patients on hospice for years.
Mm-hmm.
Yeah.
Exactly. And most of the time, people on hospice, they live for years because the quality of their life gets so much better.
Right.
Yeah. And because you have a team of nurses and doctors and nurse practitioners and social workers and a chaplain and this group of people that helps you to live a much more fulfilled life because you're not
going to doctor's appointments
correct.
Constantly, being hospitalized all the time. Yeah,
exactly.
So that in itself is hospice. So then where does palliative care kind of come in between that? What is palliative care? Because like you said, a lot of people don't know about it and they don't know it's an option. They think hospice is the only option. And then they like we mentioned, they associate it with I'm dying right now today.
Yes. They're like, oh, no, palliative comes in. I'm not dying. So why are you here?
Right.
So palliative is the bridge kind of in between home health and hospice. So it's a lot of the time symptom management. So you have these specialized physicians and nurse practitioners. So it's for people with chronic, serious medical problems that still want to do all the things. So they have COPD or chronic respiratory failure or sickle cell or heart failure or any serious medical problem that impacts their quality of life or, like they're on dialysis or they have cancers, all the things, right? But they still want to do the things, meaning they still go to the cancer center to get chemotherapy or dialysis, and they do the things. They still get the treatments.
And we should, I'm sorry to interrupt you, but like that's one of the difference between hospice and palliative care, because when you do go on hospice, you do have to give up those treatments such as chemotherapy and dialysis and stuff like that, because that's prolonging life.
Yes.
Correct?
9 times out of 10. So there is a lot of gray area, and that is in discussion, like caveat time, in discussion with your hospice team, because your primary hospice diagnosis can be what it is, like what is going to primarily end your life, right? But in some situations, so say that you have a primary hospice diagnosis of pulmonary fibrosis, right? So it is a primary lung problem that is going to kill you, right? And so say that you're on dialysis, if it's like peritoneal at home, okay? Or even if you go to a center, you may have it so that you can go to dialysis. But in discussion with your hospice team, it is probably that there will be some people that may set a limit on it, where they may be like, hey, this is for symptom management. Like, I don't want to build up fluid, but I'm still dying of my lung disease.
So basically they want to be more, it's more to make them more comfortable and not to prolong. Okay.
And they may set a limit on it where like, hey, you're going to do this for maybe a couple months and then stop. It's really patient specific and in discussion with your hospice team.
Okay. And so what have you noticed, like when you do, because you go in and have these conversations, which being in the healthcare and being a nurse practitioner, those conversations are really hard to have just because a lot of people aren't educated on it. And so like you said, we go in the room and if we mention palliative care or hospice, people instantly think, oh, you're telling me I'm dying tomorrow. And so how did you go into a room and kind of get the feel for it and kind of educate them to be like, hey, this is not meaning that I'm saying you're dying tomorrow. This is actually to help you in the long run.
That's a good question. I think like at first you definitely have a lot of awkward, horrible conversations, and you want to be the size of a pea and fall through the floor and just die yourself, honestly. And then you get better at it because you're like, oh wait, I don't have any other option and we're just going to struggle through this together. And then over time, pretty quickly, you realize, okay, we just got to get better at this and we're just going to have a great conversation. I found that having that conversation with the patient when they can, which is mostly, they're usually awake and alert or able to participate in the conversation, and then their family, be it like blood relatives or whoever their support person is, and that like the family including them in that conversation and asking them like, what do you know about what the doctors are telling you? And like, what is your quality of life? What does a good day look like to you? Like, there's so many questions that you ask really about the day to day, or like really that question, what do you know about what are the doctors telling you? And that will just spur this whole conversation. And then you'll see kind of like their own understanding open up before you. And then it just brings on more and more and more conversation, and they will get the realization usually through that. But a lot of the time, you will, through the diagnostics, like in the hospital, you'll be like, oh, okay, well, are you okay with hearing about the results of this or your lab test here? And, that spurs further conversation. This means this, or I am sorry to tell you that XYZ. Your cancer has spread to these parts, blah, 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 it's XYZ. Yeah.
So like when it comes to the difference actually with palliative care and hospice, what are some of the main differences? I know we spoke about, like you said that in theory, you should have 6 months or less to live on hospice, but we know that people have been on hospice for years. So in theory, that's one of the differences. And I guess where I'm coming from with this, like I know like hospice has a certain set of rules, like certain medications they can't have or certain things like that versus palliative care. So like, do you know some of the differences between the two that kind of stand out to you in your brain that you can recall from when you were working?
Not really. It's mostly that like, what hospice is obviously quality of life focused, where you're not prolonging life. You are focused
Well,
on,
like for
what do you mean?
Like when I worked in the ER, like I know that if people were on hospice, they were told if they went to the ER, then their hospice was like canceled or discontinued because they chose to go to the ER for life-saving measures, I guess.
That is actually interesting too, because also second caveat of the discussion, if you are on hospice, so say that you're on hospice for, I don't know, whatever, right? Like COPD.
Yeah.
But if you fall and break your hip, that's extra.
Right.
Like,
And I think it had to be about the diagnosis. So let's say you're on hospice for COPD and then you go into a COPD exacerbation and then you choose yourself, like you're like, hey, I want to go to the ER. Does that then discontinue your hospice term until you get out of the hospital and you make that decision again?
Correct.
Okay.
Yes. And then I don't know how many, but I think there's only so many times that you can revoke before you get kicked off of, I think, that company. But I think you can go to different companies, but I don't know all the rules and regulations.
And so what about palliative care? So like if let's say I'm on palliative care, I also have COPD, but I want to go to the hospital. Can I do that on palliative care?
Yes.
And then that doesn't revoke anything?
Correct. No, not at all. Because palliative is, you're getting like, quality of life is important. You also, usually people that want symptom management and palliative care, they want to usually decrease the amount of times they go to the hospital because like usually that ties into the quality of their life. But it just depends. It fluxes.
But that's one of the big differences with hospice. I know also like I know we're talking about palliative care and hospice, but like I know like treating patients, when I do have to have that hard conversation with them about going on hospice, in their minds they think that everything is stopped. Like I can't have any of my medications. I can't, and I have to try to explain to them no, like we obviously want you to like take your Lasix. We don't want you to get fluid overloaded. We are still going to check you for UTI. If you have a UTI and that's treatable, we're going to treat you. And I think a lot of people have that misconception of once they go on hospice that we're no longer going to treat you. We're no longer going to take care of you. And like you said, and just let you die. And that's not the point. Like obviously if you have congestive heart failure and you have a lot of fluid in your lungs and it feels like you're drowning, that's not quality of life and that's not passing peacefully. So of course we're going to give you those medications to make you more comfortable.
Exactly. Yes.
Like, and I know your grandfather was he on hospice or palliative care?
Hospice for a year. So did he make it a year or a little over a year? Or
close
to there? Yes.
And are you comfortable using your grandfather as an example?
Absolutely.
Okay. So I know that your grandfather had CHF, congestive heart failure for those that are not medical, where, obviously your heart's not pumping appropriately and it causes lung or fluid to then back up into the lungs. And I remember I treated your grandfather in the ER, which this is not breaking HIPAA at all. Like we're obviously talking about it in Ivy's family. But I treated your grandfather in the hospital and he was adamant he did not want to be there. Like kept telling me, I don't want to be here. Yep. But at the time he was not on hospice. He was a full code, all the things, right?
Oh, he was never a full code. Like, no, he would have been a DNR,
but yeah. he didn't want to be at the hospital.
Correct.
So that is when you as the provider and obviously working at the time and knowing the things you did, you had to sit down and did you have that conversation with him or did someone in the hospital have that conversation with him?
It was probably, I wonder if somebody may have had that conversation with him, but he and I had that conversation at one point and he decided to go with hospice. And then from then on, he didn't go back to the hospital except for one time. But that was neither here nor there.
Okay.
Which was okay because it turned out that because he got antibiotics and some IV Lasix, it did help to prolong his life. So we got some extra, like a gift. We got more months with him, which was really cool.
Right. So when did he finally make that decision to be like, okay, because I already know, like, he did not like going to the ER. He did not like being, and he hated that. He hated being admitted to the hospital. And so he was at that point, I think logically, where someone could sit down and explain to him like, hey, if you don't want to go to the hospital and you don't want to be in the ER for periods of time, hospice is a great option for you.
Yes, that was pretty much how that conversation went. And he also hated going to his PCP, absolutely hated it. He had also around that time, like, gotten a big wound on his leg because and he had to have home health, and he hated physical therapy and occupational therapy, hated wound care, hated taking medicine, hated going to the ED.
Well, I mean, most 90-year-olds sounds like a typical 90-year-old.
Yes, it was very classic. Absolutely hated all of it. He hated the medical system. Just didn't want to participate. Cool. And just hated medication burden too. So he was the perfect hospice candidate. It turned out perfect.
But how did you get someone who hates the medical system and against all that to be like, yeah, let's get these nurses to come check on you once in a while?
It turned out perfect because of that, because really it's a low burden after that. Because then, he must have been the easiest peasiest hospice patient, because then you just get your one nurse that gets to know you. He loved his hospice nurse, by the way. Shout out to Stacy. She loved my grandpa and he loved her. And she could get him to do things that no one else could. She apparently took care of his toenails. No one could do that, by the way. And she got a foot care nurse out there, which no one could do that.
He's like, no. Yeah, he told me he wouldn't marry me, so that's interesting. Interesting. Very
You
interesting.
cannot be my step grandma. Go away.
But how awesome would it have been?
No, I'm not talking to you. But it was it was perfect. He was the perfect hospice perfect hospice candidate, because he was tired of all the crap, and it was like, okay, here's your option.
Right.
Cool. Because you're not forced to do therapy, and here's the medications to keep your quality of life intact and better. Okay, awesome.
Take them if you want.
Yes.
Don't take them if you don't want.
Correct. And he surely did not. So there we go.
And that is the good thing about hospice. And I wish it didn't have such a taboo, negative connotation around it, because people do instantly think, you're not going to take care of me. You're just going to let me die.
Yep.
When that's not
Unfortunately,
true.
yeah.
Yeah.
And also, I guess fifth caveat of the episode, at the end of my grandpa's life, he, what I did not recognize, but I guess it's because he's my grandpa, and in those situations,
you can't treat your family.
No. Yeah. And you don't recognize things because they're your family, and you're just too close. And I love my grandpa, and you just don't see things. He had, terminal agitation and delirium, probably from pain, because I think talking about it, maybe hopefully someone else will recognize this in their loved one. He had fallen about 2 weeks before he died, and may or may not have fractured his back. We will never know, because it's unnecessary to take someone who is very frail and elderly to get them imaged, because you're not going to treat. Yes, yeah. You're not going to take him back to surgery, because that's unnecessary and stupid, right?
Right.
And a TLSO brace, what I found out, is extremely expensive, and you're not going to put a 93-year-old in a horrific TLSO brace that they're going to hate.
They typically take it off anyways.
Correct.
Yeah.
Because it's very unwieldy, uncomfortable, and he was in pain. So he was in what was terminal agitation. We later, hindsight is always 20/20. So about a couple days before he died, his hospice nurse recognized it, and he was finally okayed to send him to inpatient hospice. His hospice nurse got him there, without getting too personal. Jonna knows the story, but how we finally got him there, it was wonderful, and it was heaven sent, is all I will say.
Yeah.
But that was the best experience of, I think, his entire life.
So what is the difference then with inpatient hospice and outpatient hospice? And is there a certain qualification of patients that meet criteria to be in inpatient hospice?
That's a good question. There's different levels. And so my grandpa had what is outpatient hospice, the typical day-to-day, which means that he had a qualifying diagnosis, which I think was coronary artery disease, if I'm not mistaken. And maybe malnutrition, I think, because he was really skinny there for a while. I don't know what his hospice diagnoses were, but he qualified.
Yeah.
And then as he became symptomatic, which means he was terminally agitated, and his symptoms could not be managed in the home setting because he was not able to swallow, and his cognition was declining.
Was he requiring more rounds of pain medicine too? Where you would have to be monitored more?
Yes.
Okay.
And we had difficulty getting it to him.
Okay.
Is all I will say.
Yeah.
There's different ways. Like, so they do, when somebody's on hospice, you have medications that are prescribed. Usually it's liquid morphine and Ativan. There's different ones that the medical director and the nurses will deem necessary.
Yeah.
But they couldn't administer it to him.
Yeah.
And it'll be different ways that, like, they'll say your patient isn't responding, or you can't give it to them because of XYZ.
Yeah.
Either they're spitting it out or they're unconscious. You can't get it to them.
And he was having difficulty swallowing. So
yeah,
even the liquid would be hard for him to swallow. So
yes. And I'm trying to think of the reason why, he was very agitated. We got him there because he qualified for respite care. That is the other level.
Okay,
so
I've never heard of respite care.
It is, I don't know how many, you get 1 or 2 benefit periods of respite care. I think it's 5 days per benefit period of hospice. So it's a couple of times a year. So your person on hospice gets respite care at inpatient hospice, which means that they get 5 days at the inpatient hospice facility. So they just get to be there.
Okay.
And he qualified for that. But he was also declining and actively dying, in that time. Mm-hmm. So he turned to inpatient hospice status while he was there.
Okay.
Because it just happened to be actively dying.
Right.
And he was very comfortable.
Good.
Yeah.
And that's the way, like, we all want, like, people to go, like, our family members, like, even myself, like, I want to die peacefully. Most people are like, I want to die peacefully in my home. And and, you know, working in the ER, I've seen it both ways, where people unfortunately will revoke hospice or revoke, like, full codes and DNRs and stuff, which we'll get into in a little bit, because I hate Ivy's thoughts on this sometimes. But
we're going there. We're going there. Okay.
There. And is there anything that you can think of, like hospice or palliative care, that we didn't touch on?
Ooh, you're putting me on the spot. My brain is not working. It's Friday. I'm trying to think. I guess one more thing about inpatient hospice. Just, I guess, shout out, real 1990s term. Shout out to his team at inpatient hospice. Like, it is there for acute management of. It's like an acute hospice hospital is how I phrase it.
Right.
They take wonderful care of hospice symptoms at end of life. So, you know, agitation, pain, shortness of breath, terminal secretions, or what we know of as the gurgle, so to speak, bowel management issues, urinary difficulties, things like that. Like anything that can cause difficulty in dying, they take care of. So they help people to die with peace and dignity.
And with being on hospice, this is maybe a stupid question, but just for listeners who want to know, like, a full code, meaning you want everything done, CPR, chest compressions, intubation, and being a DNR, meaning do not resuscitate me. And there's 2 different types of DNR. There's a DNI, which is do not intubate, and then there's a DNR, which is like, you still want to be intubated, but you don't want compressions, which I've never understood. Mm-hmm. But on hospice, do you have to be a DNR?
No, interestingly. And I find that unique.
It's weird, right? It's
correct.
Different.
Yes.
Because it's like, you know that you're doing it because you're not trying to prolong life, but then when you're a full code, you're prolonging life.
Correct. I find that very unique. However, I guess everybody has the ability to choose anything. But I guess we're about to get into a code discussion. But yes, correct. If you want to go on hospice, you do not have to be a do not resuscitate nor do not intubate. But that discussion is had with a goals of care discussion, you know, so
okay,
absolutely.
So now getting into this code discussion, that's another awkward conversation to have with patients, but not only just patients, like, it's sometimes necessary to have with your friends and family so that they know what your wishes are, because sometimes, you know, obviously, like me, for instance, I'm single. I don't have significant others. I can team, like, so since I don't have a spouse, like, if something were to happen to me, then my immediate family, which would be my mom, would then get to make decisions of my care. And if I don't have it written out, which is a, now it's lost me. What's it? A healthcare proxy? Is it
oh my God. Yeah.
What's it called when you write your stuff out? A living will?
Yeah, or healthcare directive. Oh my
God. Something like that, guys. We know.
We'll go with it.
Well, it's one of those. If you don't have it written out and your family isn't, like, aware of it, and if it's not at the, like, if you don't have it on you, facility, whatever, your family then can make whatever choice they want to make for you. I will also say this. You can have those things put in place and your family can revoke them.
Yes, they can still do whatever they want. It is horrifying.
Yeah. So like we mentioned, like CPR is like do not resuscitate. DNI is a do not intubate, meaning a tube is down your throat, breathing for you. And those are life-sustaining things to keep you alive. I have a different take on it for my life than Ivy does. And we've had this conversation many times. And I just wanted to have it on this podcast because I think it's hilarious.
She is calling me out.
Because we argue every time we have this conversation. So I do, for me personally, and everybody has their own thoughts. So this is not a judgment for anyone. This is just more like our personal preferences, right? Mm-hmm. It's no different than what kind of jeans I like. But I personally, if I'm in a car wreck at the age that I'm at now and I go to the hospital, knowing that I can be saved, knowing that they can intubate me, take me to surgery, and I will wake up then a week later and be fine, I want my life saved. However, if I'm in a car wreck, I'm deemed brain dead. I don't want any life-saving measures. Please don't do that to me. Those are logical thought processes that I feel like everyone could concur to. If I get a terminal like cancer or a terminal illness or something like that, I would also then say that I don't want to be intubated. I don't want CPR because what's the point of prolonging me 3 to 4 more months? Okay, Ivy, tell us your thoughts around this matter.
Thank you for asking. How unique.
Go ahead. Go ahead.
I feel like at my current age, if I were to get in a motor vehicle crash and I were to be intubated on scene, I would hope that my husband, who would be my next of kin, medical decision maker, would have me extubated and I would be put on comfort meds and pass away. I would hope that I would not be intubated at all. I am a do not resuscitate, do not intubate. I do not accept any physical or mental debility. None.
Even if
correct.
You were intubated for 2 days.
Blank.
Just 2 days. And guys, let's just preface this with she has 2 young boys that she's willing to leave on this earth.
Correct.
When she could be fixed and saved.
But there's no guarantee.
What if they said, we have a 98% guarantee that we can just take your spleen out and stop the internal bleeding and you will wake up next week and be completely fine, but we have to intubate you right now because you're being psychotic in the ER and being combative.
You don't know that.
I've seen it. I worked in the ER for 11 years. I've seen it. If you were on scene and your brain was split open and you already were brain dead on scene, I can understand being like, don't intubate me because what's the point? But if you were literally like breathing 3 respirations a minute because you had a liver lack, a spleen lack, and your guts were laid open, but you could literally just go have surgery and wake up in a couple weeks and you're going to have a hard road and rehab and all that ahead, but you're alive to be a mother to your children. I think that you're just seeing it as black and white. But I worked in trauma. We intubated almost every level 1 trauma. And guess what? They walked out of the hospital like 6 weeks later.
But what if you go into like major septic shock, like hypovolemic shock, then you cardiac arrest? Because what if?
That's fine. Then you tell your husband, if I am not awake and I'm not doing better in 7 to 14 days, extubate me. Those are my wishes.
Okay, that's fair. Okay, possibly, maybe my mind is changed.
Oh, really? This is the first discussion your mind has ever been changed. But like I worked at Vanderbilt in trauma. Do you know how many of those fuckers were intubated and walked out? Now, they might not have walked out till 3 months later because they had to go through physical therapy. They broke every bone in their body, but they were alive.
Okay, when you say it like that it bothers my soul. So I don't see it like that exactly. Like I don't consider it just to be like, oh, I'm so glad to be alive.
Okay, that's another problem in itself.
That bothers me when you say that. Like, oh, I'd be so glad to be alive, but
I think your mind would change if you had to go through something so horrific that you would then wake up like, that's like, for instance, I've never had anything that horrific happen to me, right? Like I've had friends that have had devastating diagnoses, whether it be breast cancer that they've survived, and then they look at life completely different. They're like, the things that I used to complain about, why? You know what I'm saying? Like if you've never had that near-death experience. Okay, well, I'll take it for instance. So my dad died dead on arrival. Instantly he died at a car wreck when I was younger. Had they intubated him at the scene and taken him in, yes, I get what you're saying. That's horrific. He's already dead. Now you have to put someone through the trauma of extubating someone that's already dead, because a lot of people, lay people, don't understand that. But if he were laying on the ground unconscious, but his heart was still beating and he was barely breathing because he was losing a lot of blood, and they could intubate him, rush him to the hospital, hook level 1 infusions up to him and rapid blood into him, and he wake up a week later and walk out of that hospital.
But that's a bunch of what ifs. My point
It's not a what if. That's gonna happen.
But it's a what if. It's what do you have at the end of all of that? My point is like, okay, say that happens right now. What if I'm unconscious, GCS of 3, get intubated? What is left, right? I don't want to leave my kids with a half of what I have right now, right?
But
like, what is life?
Because you're thinking about it you're not looking at the percentages of okay. So the percentage of that happening is very low. I'm telling you, I worked a year at trauma at Vanderbilt and I worked 11 years in the ER. Over 80% of the traumas walked out completely normal and fine.
But you could be that 20.
Yeah, so you would rather just die for 20% of I might not be the same person I was.
Possibly, yes. I don't
understand that. I just don't. I mean, we can agree to disagree. I just don't understand that, because 20% is a low percentage. And most traumas, especially with the trauma surgeons we have and how amazing they are, a lot of the traumas, and I will say the reason why a lot of the traumas get intubated on scene is because their head injuries are so severe that they're combative, so that they have to put them down because they won't stop fighting the medics. And we would have to intubate them in the ER because they were combative and fighting because they were so confused they didn't know where they were.
I mean, I get that, but at the same time, like it just life is just not this blanket statement like, oh, just a beating heart and a breathing lung is just not life, right? Like,
I get that, but I'm saying it's almost the equivalent. This is the way I hear it when you say it to me, and maybe this example will make sense. You get diagnosed with stage 1 breast cancer tomorrow. Stage 1. They say they can do a lumpectomy, put you on chemo for 2 months, and you'll be fine. You'll live. Mm-hmm. You'll just have half a breast on one side. Mm-hmm. But you tell them no because you won't be a whole person that you were. That's exactly what I hear when you say, well, I don't want them to intubate me and me possibly make it. Because there's also a huge percentage that breast cancer could recur in 5 years.
That is very different.
No, it's not.
It is very different. Mm-hmm. It is extremely different.
Both of them can kill you. Both of them. Both of them could kill you.
Leaving my kids with like a meat, like vegetating in an LTAC for the rest of my life, the possibility of that.
But do you know that percentage is low?
Still exists.
So you would rather your kids go without a mom because you didn't want to try?
Correct.
Okay. That's cool.
We're going to agree to disagree on this one.
But you just said 10 minutes ago you had possibly changed your mind because of what I said.
Yes. About, there's a glimmer of a possible mind change.
Because I'm with you. I don't want to be intubated and I don't want CPR if I'm just going to be a vegetable. I get that.
Yes.
But you're not going to know. And that's how you can have other things in place where, like, I have it in my living will. Like, if I am brain dead or if I'm not better.
Well, brain dead is dead. So right. But you don't get a choice.
But the medics aren't going to be able to diagnose you brain dead on scene.
Well, yes, absolutely. They won't.
You still have to go to the hospital. But I'm saying, like, you're not going to know that until you get to the hospital and try. And I have it in my living will. Like, if there's anything that has to prolong my life or if I have to be on a ventilator longer than 2 weeks, take it off, pull it.
Yes, that's true. Same. I have a long list of wishes.
But I'm just saying, like, the way you're saying it is you're saying absolutely no to intubation, period, end of story at all.
Well, actually what I found out is my wishes won't even get carried out because EMS has to intubate. They have to.
Because it, yeah.
So, I mean, I'm not going to get my wish anyways. Like, unless I am at home with a DNR on the refrigerator, I think. So, it doesn't matter anyways, I think. Right?
No, it does. Because if you have people with you and they can prove that you have a DNR and a DNI, they can't do it.
Okay.
Yeah.
I mean, in that small instance,
but
right?
I'm saying, like, on a car wreck, who's got their living will in their car with them?
No one.
Exactly.
So sounds like a high percentage that my ass is going to get intubated anyways.
But I'm just telling you, like, I've seen a lot of people, like, they get intubated on scene, then they end up with a trach. They're in the hospital for a while. They walk out of there the same person. Now, do they have trauma and, like, PTSD? Probably, yeah.
Yeah, I'm sure.
But I got PTSD from my floor issues in there. I'm just saying, like, do we not all have some form of PTSD? Do we not?
Can't. There is a lot of gray area in literally everything. And yes, I do have it in my living will that if there is no hope of...
Same. I have the same. Because I'm total agreement with you there.
Yes.
Like, I don't want to be sitting in a bed on a ventilator for 2 to 3 months.
No, God.
Someone praying that I'm just going to magically have a brain again. I completely get what you're saying there. Yeah. I'm just saying, like, in my mind, I'm thinking, like, how could you not, like, if you're in a car wreck or a traumatic event, like the plane falls out of the sky and, you know, your legs are severed and you just need to be intubated to be taken to surgery because you won't stop hitting the nurses.
Well, it looks like I don't have a choice anyways. So it sounds like...
I'm going to have a talk with your husband and tell him that you don't have a choice. Please make me your healthcare proxy.
That's horrific. I don't know. Ugh.
No, this was just a short conversation because we just wanted to kind of put some education out there. But if anybody has any questions about this, definitely DM us. I know it was a little bit more of a serious conversation, but we just wanted to have it. Ivy, can you think of anything else that we needed to say about the hospice, DNR, DNI, healthcare proxy, any of that?
No.
Palliative care? You think we covered it all?
I think so.
Alrighty, guys. I think the next episode we're going to try to... Ivy had a good idea about how we didn't die in the 90s. So that will be the next one for y'all. If y'all are interested in that one. If this one was a little bit too serious and morbid for you, we should have a little bit more funny and humor coming next week. So until next time, guys, bye.